Lisa Tong talk about their projects very briefly. Our keynote speaker is Dr. Michael Fiore, who'll be talking about implementation of smoking cessation interventions and guidelines from 8:30 to 9:15. We'll have a short break in the morning. We'll have a panel symposium on California's laws to restrict the sale of flavored tobacco products, including the tobacco industry referendum and impact on community health. We'll have a short break again at 10:20. We'll have a panel on Quit for COVID. And then after another short break, we'll have a breakout sessions on helping others to quit. There's 3 sessions. 2 of them you'll be assigned to a breakout room. The first one on training for clinic and behavioral staff in your county, and smoke cessation pharmacotherapy. In the main room, there'll be the other breakout session, group behavioral therapy for smoking cessation. And then at the end of the day, we'll gather back to the main room for the evaluations. The California Tobacco Research Related Disease Program had a grant entitled Community Participatory-Based Implementation Research Award. It's funded by the University of California Office of the President. There are 3 projects funded in 2018, and the goal of the TRDP Implementation Science Award is to conduct health services research that can lead to systems changes in the delivery of smoking cessation services for low-income smokers, such as the Medi-Cal population. It's funded by the California tobacco taxes, and the program officer is our good friend Norval Hickman, who was unable to join us today, but he sends us his wishes. The 3 grants are led. The first one is led by me and Dr. Hurley. It's at the Department of Health Services and Department of Mental Health and Friends Research Institute. The second one is led by Lisa Tong at UC Davis. It's assisted by Hallie and Paul Givney at the LA Department of Health Services. And the third one is led by Joseph Gaddis and Maya Ragavan at UC San Francisco. The community partners is the San Francisco Health Network and Health Rights. The goal of the DHS DMH TRDP funded smoking cessation implementation project is to embed community comprehensive smoking cessation clinics into Los Angeles County clinics. The project involves expanding, integrating clinical programs with the emphasis on smoking cessation medications plus smoking cessation counseling. And it's based on an already validated smoking cessation model employed at the Los Angeles VA hospital. It is DSH-IRB approved and DMH HSCR approved. Initially, there was 6 sites in the PCMHs, in the patient-centered medical homes, and LAC-DHS, and there was also 6 LAC-DMH operated community mental health centers. There was randomization in a 5-to-1 ratio. There's 5 PCMH sites and 5 CMHC sites, and treatment as usual is 1 PCMH site and 1 CMHC site. These are the sites listed here, the 6 DHS sites and the 6 DMH mental health sites. We recently are in the process of adding 5 additional sites: High Desert Research Health Center, Claude Hudson Center, LAC USC, which is the treatment as usual site, Long Beach Comprehensive Health, and the Olive View site in the Valley. This will expand our services. The program uses implementation, intervention, and evaluation. There's new county expected practices and policies permitting evidence-based treatments. The program in DHS uses behavioral health clinicians, and the programs in DMH use the leadership to support smoking cessation services. Both services have access to medicines such as nicotine replacement therapy, bupropion, and varenicline. And there's ongoing training, technical assistance, and decision support from the DPH Tobacco Control, DHS Addiction Medicine, and the TRD funded experts. Inclusion criteria include being 18 years or older, currently a patient in LAC, Los Angeles County Department of Health Services, or Department of Mental Health Services, smoking 3 cigarettes a day, and people that want to reduce or eliminate their tobacco product use. Exclusion is no smoking cessation medicines in the past 30 days that can't be washed out. We offer a small incentive, and the phone number if you have patients that would like to enroll in this is listed there. Okay, we're going to next hand the podium over to Lisa and Joseph. We're going to briefly talk about their projects.
So I just have a few slides. about our project. And I just want to really appreciate all of you for getting up early on a Friday for this conference, and a deep appreciation for Dr. Friedman and Hurley and their whole team for even launching this TRDRP Smoking Cessation Day. The first one was in LA County, and then the next one we did statewide. So this one is, you know, it's, I think we've had over 600 registrants. So this is amazing. Anyways, and I also appreciate that we have a fantastic lineup of speakers and topics today, including the legendary Dr. Michael Fiore, who I know many of you signed up to listen to today. So about our project, this is just a brief overview of our TRDRP research project aims. It's a collaboration across Los Angeles Department of Health Services. So it's a sister project to Dr. Friedman and Hurley's. And LADHS, as many of you may know, it's the nation's second largest municipal health system. And it's a partnership with the California Smokers Helpline, which is at UC San Diego. It's our state quit line, and also our team at UC Davis. So our project goal is to develop and evaluate implementation strategies for improving integration with our state quit line, which can be considered as an adjunct also for clinical care. But we want to develop strategies that are scalable and sustainable. So we hope to develop our products that we can demonstrate outside of LA as well. And I want to acknowledge Dr. Hal Yee and Paul Gibney, who are the Chief Medical Officer and Associate Chief Medical Officer, for their leadership on this project. Shu Hongzhu and Sharon Cummins and Carrie Kirby from the Helpline. And the rest of their team, and also our UC Davis team, Camille Cipri, Cindy Valencia, and Dr. Shinping Tu. And we have many partners and stakeholders who I see some of them are on today. So how to connect the tobacco user and work with the health system, and also work with the quit line. So we called this grant Expanding LA County e-consult cessation services, because we had a pilot to establish something called e-consult, and e-consult, a helpline referral. So our project aims was one, after we had established that e-consult referral, we saw there was room for improvement. How could we improve patient contact by the California Smokers Helpline? Aim 2 was doing a deeper dive into the provider workflow in the LADHS clinics and see what was it that we could do to improve it. And then aim 3, which I jokingly call the Holy Grail, is how do we integrate medication services a little bit better with the quit line. And this has been really exploring all options, and again, scalable and sustainable options. And one thing TRDRP asked of our projects was to conduct pilots that would benefit the larger state if we could. So we have some pilots on Latino smoking assistance. Of course, that's a very important population in LA County and for all of California. Data sharing, which is another long process, and another, I'll share just a couple highlights on this. And then also, it's maybe maybe not quite accurate to call it a pilot, but I will talk later today about Quit for COVID. So aim 1, and this is just a schematic just to show kind of an overview of what we're trying to do. You know, so a tobacco user comes to the health system. The providers typically would enter a referral in e-consult and refer to the helpline, which was considered a specialty provider in this e-consult system. And then the helpline would directly contact the tobacco user to see what services are needed. And like I said, this was a great pilot that we set up, but then we saw numbers dropping off over time. What could we do to improve this? And so at least we wanted to try to see what were ways we could help improve patient contact with the helpline. And the reason why we chose e-consult was because it was for Dr. Hal Yee and all of LADHS, it was a matter of health equity, where it wasn't just talking about LADHS clinics, but they had a responsibility to over 200 community partner clinics who take care of the My Health LA population, which is the uninsurable population. So it was a strategy to make this available to many providers and patients. And to date, we've had over 1,500 patients referred through this system, including modifications and with our strategies. And then we also saw there was a health system need to try to reach unassisted patients and what some of you may know as closing care gaps. So we also did some proactive outreach demonstration where the helpline became a partner of LADHS and contacted patients. And we were testing also to see if a local area code, as opposed to you all know the helpline is 1-800-NO-BUTS. Does this help improve contact rates? And our preliminary findings suggest it does. So how do we implement that for all of our counties? AIM 2 is doing a deeper dive into the provider workflow. And so one thing we realized was the e-consult system, which is a primary care and specialty provider communication portal, we really needed something that was easier for providers to access within their existing workflow. So what we did was we did a workflow modification in the LADHS electronic health record, which is called ORCID. And it took a while, but we did see some great results. And to date, we have more LADHS provider orders actually, and the community partner clinics, which we will help with in a pilot, their numbers have dropped off over time. We've also done a study surveying the LADHS provider perspective about tobacco treatment and the helpline. What are their needs? How can we make things better? And then we're doing also some interviews with those providers who have utilized the e-consult and ORCID order to see what are their perspectives as well. And finally, for the third aim, it's medication integration. And many of you have asked me also, how can we sustain this? So, and I as a provider also would love to see this. So we've been exploring many different options for plan covered medications. The California Tobacco Control Program it doesn't fund nicotine patches as it's considered a health service, a covered health benefit. So the helpline, their special offers have typically been grant funded or from other sources that counties have. We've talked with Medi-Cal here in Sacramento. As many of you may know, there's this whole restructuring of Medi-Cal, and there's something this year that's going to be hopefully launched. It's been delayed a couple times, but it's called Medi-Cal RX, where they're trying to streamline everything, at least for the paperwork side. But from what we've understood, the managed care plans are still responsible for managing their populations, utilization and chronic disease management. So, and there's 26 Medi-Cal managed care plans, so it's a very complex scenario, but how can we integrate the helpline into this? How can the the helpline is not a traditional provider. It serves, it serves thousands of people every year. So it's not really feasible for one doctor, for example, to prescribe all that medication. And one thing we've been exploring more is that community pharmacies may play a very important role, and this is something that, that we've heard from different stakeholders. And California community pharmacists, they can furnish nicotine replacement therapy without a prescription. They just need to do a 2-hour training to and keep track. They can also provide services like oral contraceptives as well, and immunizations, as many of you may know. And so one thing we're trying to pilot is having the helpline fax caller info to the pharmacies directly, because they're already connected to them. And finally, the 3 pilots, as mentioned, Latino smoking assistance. Cindy Valencia on our team has been looking at the California Health Interview Survey. It's been described nationwide that Latinos have lower provider advice than other racial ethnic groups. And why is this? So we took a deeper dive looking at California after the Affordable Care Act. And she just presented this at the Society for Research on Nicotine and Tobacco last week, where we have been finding that the Latinos who smoke, they actually don't go to the doctor. And in a COVID pandemic year, that's actually even more important now. And so if you're not going to the doctor, how are you getting assistance? And we know also that Latinos tend to smoke lighter for various reasons. And so it may not need the traditional medication, heavy smoker phenomenon that we are typically thinking of for smokers. So how do we develop other strategies? And one of them that we're piloting is with one of the Medi-Cal managed care plans, Current Family Health Care Plan, who requested a promotorist training with American Cancer Society's Fresh Start curriculum. And thankfully, American Cancer Society gave us permission to help translate these materials for the plans. And we hope this is something that all the plans can share in as well. The pilot number 2, data sharing with the helpline. This is the part where contracts are very important, or agreements, but what we want to do is figure out how to reach all those other community partner clinics. There are health information exchanges throughout California, and in LA County, it's lanes. And so we've been talking with them about how can we build a portal that's accessible for all the community partner clinics. The LADHS e-consult system is only meant for my And finally, we've been also some of our important stakeholders, HealthNet and LA Care, their Medi-Cal managed care plans have agreements set up now with the helpline to establish smoker registries. And we're trying to explore how else can we build upon this and also share it with other plans. And I'll save the quit for COVID part for the panel presentation later, but this is just as a teaser. We have some great news about this statewide campaign and public health promotion partnership and with our research team.
Okay, thank you, Dr. Tom. We're going to have Brianna Lopez come on and explain a little bit about the CME, the CE process, but we'll have the main part at the end. And for everyone's information, we did send out bios for all of the speakers. You see how quickly we're going through this. So we want to save as much time as possible for the actual presentations. And the slides, the recordings will be provided after the event.
For those asking for CME credits, so continuing medical education credits, there will be a maximum of 4.25 credits available. It will depend on how many minutes you were on this call in total. And also we're offering CE hours for those that ask for continuing education hours. And that is based on if you were here throughout the whole event. They do not give partial credit for anyone that was here for only partial event. If you have any questions, you can also send a chat to me privately, and we will be sending the links to the surveys for the CMEs and the CEs at the end. For the CEs, there will be a post test that goes over what was talked about in this webinar, and you have to have at least an 80% to receive that credit. And for the CMEs, it will be just an overview of how you liked the webinar. And also there will be a GIPRA, and a GIPRA is for those that are giving credit for us to do this webinar. And we would ask that everyone can do the GIPRA evaluation at the end. It just gives us an idea of what we can improve on for next year. And that's it.
Sorry, we talked about all of these already.
Yes, I was quick, sorry.
Yeah, you are. No, that's great. Okay, for the GEPRA evaluation, this is your start code. You will need this to confirm that you were here, early on, so that you can get credit for all of your hours. So please make note of this code. It will not be shown again. 2117. Thank you.
Norma, let's have Joseph give a quick presentation of this project.
I'm sorry, Dr. Gaddis, go ahead.
Hi everyone. My name is Joe Gaddis, University of California, San Francisco. If for those of you who are joining a little bit late, I think the structure here has been that Dr. Friedman and Dr. Tong and I are three investigators who have funding from our tobacco-related disease research program here in California, and Dr. Friedman and his team principally have put together this day where we all get to hear about each other's work, and we have some very fine speakers. I've been asked to speak a little bit about my project. I'm going to do that very briefly. I don't have slides to share with you. I have a feeling you'll see enough slides throughout the day. And actually, I see that Dr. Norval Hickman has joined us. since I see Norval Hickman joining us, I'm just going to shout out to him to say that it was Norval Hickman's vision some 4 or 5 years ago to put together the coalition of investigators here in California that are working on these projects. So, you know, I think to summarize the driving theme of what Dr. Friedman and Dr. Tong and I are doing in response to Norval's vision and TRDRP's vision is that we're trying to find ways to reach smokers where most of them are. So we're moving away from some of the general population level interventions, and we're moving toward interventions for harder to reach populations. Those are low income primary care populations, homeless populations, populations that have mental health problems. And in my case, I work with substance use treatment programs. So just a little bit about substance use and substance use treatment. About 70%, you know, in California, we have 11.2% smoking prevalence right now. But in our substance use treatment programs, we have 70% smoking prevalence. So that's where a lot of smokers are concentrated. And there's also good data to show now that people who enter substance use treatment who smoke downstream are much more likely to die of tobacco-related causes than they are to die of their substance-related causes. So I think it's a fine time to intervene with these populations when they're in our treatment system. Sadly, we don't do that. We don't do that very well. And that's the challenge that I, together with some of my colleagues, Smoking Cessation Leadership Center and Maya Vichar-Raghavan, who's been mentioned, and our California Tobacco Control Program, we're kind of taking up the challenge to try to work with SUD treatment programs to help them more effectively address smoking. We can do this in a number of ways, but the principal way that we're trying to approach it is through policy change and tobacco-free grounds policies. So if people come into a substance use treatment program, just as when they come into a hospital or a primary care clinic or a VA setting or a college university, they're not allowed to smoke on the grounds. So tobacco-free grounds policies make it harder for people. They don't require that people quit smoking, but they do make it harder for people to stop. And then together with that, we try to provide services so that people have an opportunity to try to quit and to quit. And that's really the substance of our project. In California, I know there are people from many states here, and many different states have different policies in this area. New York and New Jersey, for example, have really experimented with statewide policies for tobacco-free grounds in these programs. But just to see how big the problem is in California, we have about 2,000 substance use treatment programs that are licensed and funded by the state. Our state regulatory agencies offer no comment. They're basically silent with regard to smoking and tobacco use. But entering those programs are about 130,000 smokers every year in California. So if you were to touch those smokers who enter treatment every year, and I know all of them would not quit, but all of them would have an opportunity to quit. But you would reach about 500,000. In 4 years' time, you would reach 500,000 smokers in California. Now, we only have 3.3 million smokers in California. So if you could touch these people over a period of time, you'd be reaching a large portion of our California state smoking population. That's one reason why this is a priority population for our California Tobacco Control Program. I think I'm going to stop there, except I will add that Dr. Kathy McDonald at 11:30 is giving a breakout on this particular topic. And if you'd like to hear more about this topic, she's really one of our statewide experts. She has led the charge for tobacco-free programs in Alameda County for a long time now. She leads the charge on behalf of the California Society of Addiction Medicine. So if you're interested, you can hear more there. Norma, I'll return it to you.
Again, I want to say welcome to all of you. And thanks for coming out and joining us today. And I just want to help to set the stage for what we'll be thinking about and the information that will be being presented today and how we might relate to the patients, clients that you serve in using this information and what you'll do with the information when you leave. I'm Norma Stokes. I'm a community engagement and tobacco treatment specialist working with the project here in Los Angeles. I spent most of my time during my career, helping to build and run nonprofits in South Los Angeles and similar communities. By similar, I mean communities where health disparities abound. As you're all probably aware, smoking has been shown to have a direct causal or significantly exacerbating relationship to many health illnesses and diseases. Moreover, research shows that smoking can be detrimental to all systems of the body. As a community engagement specialist, one of my roles in this project is to help ensure that we keep the real goal of our work at the forefront. We do the work we do to help our patients, our clients, have a better quality of life, moreover, to help save lives. But some days I do feel like I'm a casualty of trauma and disparities. These are some of the reasons. My maternal and paternal grandmothers died from strokes, and one also had diabetes. My mom was killed in an accident while working for LA County. Elevator crushed her. She was a smoker too. One brother was murdered about 6 months after mom passed away. Another brother, a smoker, died from colon cancer after a botched surgery while incarcerated. One more brother had a series of strokes, and we suspect it was a stroke that caused him to crash his car on the freeway one day and died from internal injuries. Oh, I'm just getting started. My sister died at the age of 50 about 3 years ago. She had Parkinson's, diabetes, high blood pressure, and asthma. And did I say that she was a smoker? Her husband passed last month from cancer. He smoked as well. I haven't touched on the mental health and HIV/AIDS cases in the family and in dear friends, most of whom also smoke. My dad and dear friend, and since the 7th grade, also died from smoking. And I'm going to stop here talking about all of the trauma that I've experienced, and thank God I no longer smoke. It's been over 30 years. So you see, my work with the Smoking Cessation Project as a community engagement specialist is personal. I realize that I'm but a step away from being one of the statistics we'll hear about today. I want to help see that others don't have to watch family and friends suffer and die from smoking-related illnesses as I've done. The best plan is to prevent ever starting to smoke. The second best plan is to intervene as soon as possible. I believe that integrating smoking cessation services into medical and mental health clinics is moving Los Angeles County in the right direction. I'm proud to be a part of the team and look forward to better outcomes for patients struggling to change their behaviors around smoking. I figure that I must be still standing and have great health at I am 71 now, for some reason, and so I continue to do the work that I do. Again, thank you and welcome.